Good morning. I call the PTAC to order. Welcome to day 2 of the public meeting of the Physician-Focused Payment Model Technical Advisory Committee, known as PTAC. My name is Dr. Lee Mills. I'm one of the co-chairs of PTAC, along with Dr. Gianni. Yesterday, we had a number of experts share their perspectives on using data and health information technology to transparently empower consumers and support providers. Today, we have a great lineup of experts for 2 separate sessions. The first session is focused on data-driven approaches to enabling patients with chronic conditions and enhancing secondary prevention. And the final session will be focusing on payment models and benefit designs, improvements to enhance patient empowerment. The committee has also made considerable effort to include a variety of perspectives throughout this 2-day meeting, including the viewpoints of a previous PTAC submitter. Later this afternoon, we will have a public comment period and welcome participants either in person or by telephone to share viewpoints and to share comment related to the meeting's topic. As a reminder, public commenters will be limited to 3 minutes each. If you have not registered to give an oral public comment but would like to do so, please reach out and email ptacregistration@norc.org. That's ptacregistration@norc.org prior to the public comment period at 1:05 p.m. Eastern Time. Then the committee will discuss our comments and recommendations for the report to the Secretary. Because we might have some folks online who weren't able to join yesterday, I'd like the committee members to please introduce themselves, share your name, your organization, and if you'd like, tell us about your experience with our topic. And I'll cue each of you in turn. I'll start. My name is Lee Mills. I'm a family physician and currently serve as Chief Medical Officer of Aetna Better Health of Oklahoma, one of the state's managed Medicaid plans. I served after starting in private practice in rural Kansas, started in multi-specialty medical group and health system leadership, and have had the pleasure to practice in or help lead operations in 5 or 6 different CMMI models over the past 20 years. Gianni?
Good morning, Gianni. I'm a family physician by trade, have practiced about 15 years in suburban Chicago, led a large multi-specialty group, as well as served as the chief clinical executive at Walmart Health, having spent about 20 years in implementing value-based care. Currently, I serve as the chief medical officer of Stellar Health, a value-based care enablement company, as well as have founded a company in genetics and most recently consumer-based AI navigation tools. Thank you.
I'm Jay Feldstein. I'm originally trained as an emergency medicine physician, practiced emergency medicine for 10 years, then was in the health insurance world, both commercial and government lines for close to 14 years. And have been the president of Philadelphia College of Osteopathic Medicine for the last 11, and have been a PTAC member for 6 years.
Thanks, Jay. I'm Krishna Ramachandran, Chief Information Officer, Operations and Experience for United Healthcare. Healthcare for 23 years, tech, payer, provider segments. Data and technology have been topics close to my heart, so I'm excited to be the lead for the PCDT team here for this meeting as well. Lindsay?
Thanks, Krishna. Good morning. I'm Lindsay Botsford. I'm a practicing family physician in Houston, Texas, where I care for patients, including Medicare beneficiaries. I also serve as the medical director for the Midwest and Texas with One Medical. I've been a participant provider in multiple CMMI models and am currently the chair of the governing body of our ACO REACH entity for One Medical.
Good morning. Walter Lin, the founder of Generation Clinical Partners, independent medical practice based in St. Louis that cares for the frail elderly in nursing homes and assisted living facilities. I'm also the clinical strategy officer for LTC ACO, as well as medical director for various programs, value-based programs, including a PACE program and institutional special needs plan.
Larry, go ahead.
Good morning. I'm Dr. Larry Kaczynski. I'm a retired gastroenterologist. I practiced for 35 years in the Chicagoland metropolitan area, helping build the largest GI group in Illinois that is now part of the GI Alliance, the largest independent GI practice in the country. 10 years ago, I started a value-based company named Sonar MD, which actually was started in the commercial space following a PTAC presentation. We were actually the first PTAC recommended physician-focused payment model in April of 2017. Currently today, I'm the Chief Medical Officer for Jonah, which is an AI-powered microbiome company. And I have another startup, Vocnomics AI, which is a company built around a wellness product that uses AI to enable patients to monitor their soluble fiber intake to control their weight. It's deployed in the obesity space. I've been on the committee for 4 years. I'm happy to participate today.
Thanks, Larry. Go ahead, Josh.
Good morning, everyone. Josh Lau, internal medicine physician and professor at UT Southwestern Medical Center. Over time, I've had the privilege of conducting research, doing evaluations, implementing and leading programs, thinking about strategy, and working with a number of state and federal decision makers on issues related to payment models and delivery models. In the course of doing that, obviously, I've grappled with data and its multiple different forms, claims, EHR, patient-generated, multiple data sources. And so I'm excited about continuing this conversation today.
Thank you, Josh. Thank you all. For today's agenda, we're going to explore a range of topics on using data and health information technology to transparently empower consumers and support providers. The background materials for the public meeting, including an environmental scan, will be posted online at the ASPE PTAC website meeting page, which is publicly available. The discussions, materials, and public comments from this meeting will inform a report to the Secretary of HHS on our topic, using data and health information technology to empower consumers and support providers. Lastly, I'll note that, as always, the committee is ready to receive proposals on possible innovative approaches and solutions related to care delivery, payment, or other policy issues from the public on a rolling basis. We offer 2 different submission tracks for submitters, allowing flexibility depending on the level of detail of their payment methodology. You can find information about submitting a proposal on the ASPE PTAC website. And now I'm excited to hand it over to Krishna to welcome and facilitate our first session. Krishna.
Thank you, Dee. Hi, team. As I mentioned, Krishna, one of the members and was the lead for the Preliminary Comments Development Team, so PCDT, for this meeting. For this meeting, in this section particularly, we've invited 4 esteemed experts to discuss their perspectives on data-driven approaches for enabling patients with chronic conditions and enhancing secondary prevention. You can find their full biographies and slides posted on the ASPE PTAC website and the public meeting registration site. This time, I'll ask our session participants to go ahead and turn on video if you haven't done so already. Thank you all. After all the experts have presented, the committee will have plenty of time to ask questions and engage in what we hope to be a robust discussion. We actually have 2 speakers on video and then 2 in person as well. So thank you for joining us live here in DC. Presenting first, though, will be Dr. Charles Senteio, an associate professor in the Department of Library and Information Science at Rutgers University School of Communication and Information. Charles, welcome to PTAC.
Good morning, and thank you. Thank you for the opportunity to share this perspective and this very important work. My work focuses on how we can center the patient's lived experiences, collecting information and using it accordingly, especially psychosocial and social needs information in the care process, and how respectful AI-enabled tools can help make this information accessible before, during, and after clinical encounters. Next slide, please. As a health equity researcher and licensed clinician, I examine how patient experiences such as stress, perceived discrimination, and caregiver burdens affect chronic disease care. As an information scientist, I study digital tools that elicit and summarize this data for clinical use. My work complements other panelists by focusing upstream at the point of patient engagement, while platforms like CareCore support downstream coordination. Next slide. Whether in primary or specialty care, we understand that there is more to patients than just in their diagnosis. Actually, we've known this in care delivery for quite some time. Patients live with much more than just their diagnoses and their clinical conditions. But that lived experience is not fully captured in the EHR. When we think about reasons why patients don't fill a prescription, for example, that information is not as reified, not as defined as, say, their height, their weight, their payer status. So simply, that information, even if it were collected routinely, is not easy to collect in our current tools. And that's been the case for quite some time. But new technology is making that information more accessible. As many of us can relate, there are many different reasons, and those reasons can be updated almost daily in why or why not we may take a medication or not, or why our dietary practices or our physical activity may be what it is. So I think most of us can relate to some of the challenges and some of the decisions and some of the information that informs decisions that patients, particularly patients with chronic decisions make, or chronic diseases make. And disclosing that information happens more fully when we are in respectful, trusted environments. And AI tools can help with that. There's some early evidence on that. Next slide, please. We have two promising paths. First, pre-visit AI avatars or chatbots enable private, stigma-free disclosure of sensitive experiences, like why patients may or may not take medications or even fill a script. Disclosure of sensitive experiences, such as trauma in a care delivery setting or outside of a care delivery setting. This has been validated in several care settings, including emergency departments. Generative AI tools tailored with social determinants of health aware prompting, such as in heart failure dialogue models, has shown that they can in fact enhance the quality of dialogue through empathetic engagement. It still lags behind human interaction, but I think that the trends are headed in that direction if we keep these things top of mind in terms of empathy and simulating that, or to the degree we can, simulating that approach. Second, in-visit AI prompts, like those piloted at Stanford, support clinicians in addressing these needs during care. They report that Chat EHR is a conversational AI-enabled tool that's integrated into Stanford's EHR system. It enables clinicians to query patient records and generate summaries. These kinds of tools complement downstream platforms like CareCo by enriching the upstream data that care coordinators and other clinicians can act upon. Next slide, please. So when tools are designed with empathy and dignity and respect in mind, in terms of language, in terms of tone, even in terms of appearance, patients tend to engage and disclose to tools. When providers are given brief, relevant summaries or AI-enabled prompts, they are more confident in tailoring their care. What can result is better chronic disease management, fewer missed red flags, and enhanced increased trust. There are indicators that under certain circumstances, the use of technology-enabled tools can result in a reduced emergency use and increased follow-up care. And this is true for communities that are historically underserved. Next slide, please. So to manage chronic disease, or to better manage chronic disease, we must treat more than symptoms, and we've known this for quite some time. We must treat people and keep people at that center. That requires understanding their lives, their lived experiences. We already have the data, the tools to gather this data and this information at scale. What we need to do is keep top of mind the importance of empathy and what that has to do with disclosure of information, as well as how that information may be used. Respect and technology are not opposing forces. They can be part of a formula that results in better outcomes, a noble objective which unites us all. And I have references should you
Well,
choose
thank you,
to follow up. Thank you.
Thank you so much. Appreciate it. We'll save all questions from the committee until the end of our presentations, but thank you. Next up, let's move to Dr. Gianni Neal, who serves as Chief Medical Officer for ChenMed. Gianni, thank you for joining us, and please go ahead.
It is my pleasure to speak to the PTAC committee and my colleagues in the space today on a little bit about what we're doing at ChenMed, how we're using technology to empower our patients, and leave you with some thoughts about where the gaps may be that we can lean into for our patients to experience better care in the future. Next slide. And so this is a little bit about me. I won't spend too much time, but I've been with ChenMed for about 12 years. I started as a primary care provider. I'm internal medicine pediatrics trained, now focusing on the adult and aging population, and also making sure that we are providing for our patients that we serve in 111 states, 111 centers across 12 states. Next slide. So this is a little bit about the company's setup and our snapshot. For those of you who are not familiar with ChenMed and how we operate, it's really important to understand the people that we serve and the structure of the model to really begin to understand where the gaps may be and where technology can be improved to help us deliver this care. And so we started as a family-owned company, and we still are to this day. For over 3 decades, we've served the underserved population, and we have a bold and lofty vision to be the most influential primary care provider in the cities that we're serving, transforming care for seniors while strengthening their communities, achieving better outcomes, and lowering total healthcare costs at the same time. And so across our footprint, we employ about 4,000 team members that rally around the PCPs to serve patients that are medically complex. Our average number of chronic conditions is about 5. And then we have 30% of our patient population who are partial or full dual. And in addition to that, about another 40% of the remainder of the population are LIS eligible. So needless to say, we are serving people who are truly underserved, and many of whom are given about $30,000 or less than that on which to live for the year. We operate, again, in 111 locations across 12 states under 3 brands. Our flagship is Chen Senior here in South Florida, GenCare Senior Medical Center, and Dedicated Senior Medical Center are our other 2 brands. Next slide. And so for this slide, I really want to start with a little bit of imagery about a real patient that I recently saw on one of my trips to visit the centers in New Orleans. So imagine a woman, she's a grandmother, she's in her mid-70s, and she's actually at the visit with her granddaughter. Why? Because she is the caregiver while her parents are working. She, however, has COPD, and it's not well controlled. And while the clinic is working very hard with her to be able to help her to control her COPD, she has trouble affording those very expensive inhalers. And so we're working with her to try to see how can we help her with the cost, help her with her chronic illness, and allow her to exist and be present for caring for her family. Now you can begin to see how we believe that caring for these patients also leads to strengthening these communities. In these communities, the elderly patients, those grandmothers and grandfathers, they are the ones that are doing the work of home while their children, their relatives, their neighbors are out actually working in the space. And so we believe that these patients really do need us to be there for them and give them more good days. You'll see at the top the urgent pursuit of more good days. That is the first line in our big vision. And by more good days, we mean that the patients are doing what they like to do with agency, increasing not only their lifespan, but their health span. We want them to be healthy. We want them to experience that quality of life. And so I'll draw your attention to the wheel that we have there. And this is essentially a pictorial representation of our model. At the center is the patient, which is the focus of everything that we do. And it begins with detecting what high-risk disease situations do they already have, and how can we predict and prevent the next thing from happening. And so we have a detective hat that we wear, and we want to be ahead of and not behind chronic illnesses for our patients, and want to make sure that they are managed exquisitely well. And we do this through surrounding a PCP who has a reduced panel with care team members that are supporting them as they care for that patient. They coordinate not only what happens within our centers, but they also need to coordinate what happens outside of the center, external to the patient. So when that patient is engaging, for example, with ERs, hospitals, specialists, we need to make sure that that's a highly coordinated event to decrease error and make sure that we're not experiencing a fragmentation of care for that patient. And then we have ongoing patient engagement, education, and empowerment. We are trying to build communities. And so we make our centers a go-to place for the community. They come in, they're not only able to receive a cup of coffee or a little something to eat on their way in, but they can also come for exercise classes, for cooking classes, for an expert advice on a relevant topic for seniors. And so we make our centers a beacon in the communities. And because they experience, I told you a little bit before about the socioeconomic status of our patients, we also need to provide for them real needs that they have. So transportation to the centers. We need to help them with affording their medications. We are aware that they have housing instability, food insecurity, and these are the factors that we're trying to go after as we build these communities in the places that we serve. Next slide. And so this is a busy slide, but I'll walk you through it. This is the patient care journey at ChenMed. And so I mentioned before that our patients are assigned to physicians and they have a reduced panel compared to our fee-for-service counterparts. We expect our physicians to empower and build immense trust with their patients so that they remain top of mind for those patients should any medical problem arise or they experience any change in their health. And so we give our patients, for example, their PCP cell phone number, and we actually lock it into their cell phone at the first visit that they have with their PCP so that they can know this is my doctor calling, or they can text their doctor if they have any issues. We have a comprehensive care approach where we're really seeking, as I mentioned before, not only to manage what's there, but also to prevent what's coming as much as is within our power. And so we do a robust set of screening. We see them often to monitor for even subtle changes in their health. We want to make sure that we're checking on them. We have folks that live in the cold, for example, when it is really cold outside, or if they don't have the means to be able to heat their homes, we want to be a source of heat for them. So we go and get them and bring them into the center and keep them there to keep them well throughout those times. The patient and the PCP really act as team members and the family extenders as well. And we call ourselves co-pilots because we really want to be holding that patient and their family's hand through their experience with healthcare. As you know, many of our patients, our average age is about 72. And so we're actually holding their hand with them through the last decade of their lives in most cases. And so we take that very seriously. And then, of course, we are going to have to refer them outside of our care model at times to receive specialist care, specialist intervention, or even emergency services. And so we want to make sure that when we're doing that, that we're getting the information in a timely manner so that we can also make updates to their care plans without any delay or confusion or overlap, for the patient that could be bad for them. For example, when they go to the hospital and they get a new medication, we really need to reconcile that medication list pretty quickly because the patient will take duplications if they're not careful. And if there's not a system that really reconciles that between the outpatient and the inpatient, it really leaves a lot of room for error. And so we aim to see our patients within 24 to 48 hours to do that reconciliation to prevent those errors from happening. Of course, we want to make sure that we're with them no matter where they are in the healthcare continuum, whether that be in receiving a home health within their home or at a skilled nursing facility, a rehab facility, or a long-term chronic care facility. Next slide. And so the way in which we empower our patients really is illustrated in the previous demonstration of the model, but there are gaps there that technology and improvements in communication could really help us fill. Obviously, we empower our PCPs and equip them to have really strong relationships with their patients, but we do need to be able to have them be able to interact with us and even detect when there are changes in their health while they're at home, preventing them from having to have the stigma or the hesitation of calling to say, hey, this is going wrong. I need help with X or Y. And so we interact with them frequently, but we know that this is a way in which we can help empower them. And there are many AI tools that are arising, and we want to be able to decrease the barrier for the patients to be able to access those tools into the future. Internal care coordination and infrastructure really helps us to ensure that the specialists that we have internally, whether they're contracted or employed, are serving those patients in a timely manner. It becomes more difficult when they have to go outside of our model. And so separate EMRs, separate systems that don't really coordinate with each other or talk to each other has truly been a barrier for us. Health information exchange information, state to state, varies in the timeliness that we are able to receive it and act upon it. And it truly helps us immensely when we can get that information in a timely manner. And so removing some of these barriers to communicating with health information exchange on behalf of our patients, it really does help us to keep care coordination tight and prevent the patient from experiencing an error in medical care. And lastly, our PCPs are basically our chronic disease health coaches for our patients. And so if we have technology that we can deploy to the underserved, removing those payment barriers, that whether they be wearable devices or ambient devices, really will help us to get more information into our clinics to prevent that ER arrival in the future. Next slide. So these are basically, I think I talked through most of this slide, and the other slide that I have is really in response to the questions that have come up. But I'm happy to continue to talk through them as we go into the dialogues, the dialogue portion of the session. But really, you can kind of see with the continuum of care that we provide here at ChenMed, how it's truly important for us to have more integrated resources, getting more information at our fingertips, truly being able to quarterback the care for our patients and decrease fragmentation. I thank you for your time, and I'll hand it back over to the host.
Thank you, Gianni. Next, we are happy to welcome in person Mr. Mendel Erlenwein, who is the founder and chief executive officer of CareCo. Welcome, Mendel.
Thank you so much. First of all, good morning and thank you to the committee members and to the co-chairs. This is really an honor to be here. And had a chance to talk with Khue a little before and hearing the other two panelists today. There seems to be a lot of similarity and synergies around some of these concepts that we'll talk about today. And so my name is Mendel. I'm obsessed with value-based care and very specifically care coordination. I've spent the last, let's see how this clicker works. Nice. Today I'm the CEO of CareCo, which we'll talk about, but CareCo was built off of the last 8 years that I've spent building a service-based care coordination company. And so we talk to thousands of patients a month, doing programs like chronic care management, transitional care management, and annual wellness visits. The 7 years of building that company and seeing the impact that really good care coordination can have on patients when done correctly really gave me, I think, two things. First of all, a really deep appreciation for care coordination. I know that in healthcare, every part of healthcare is the most undervalued and underappreciated part of healthcare. But I think from within healthcare, care coordination, I think, takes that prize. And that's because when care coordination is done correctly, it really becomes the foundation for the entire patient's experience with healthcare. We would have patients that would go to their primary care doctor, and it would be a whirlwind. They'd go in, doctor would come in, doctor would go out, they'd go home, they'd call their care coordinator, and they'd ask them to look at the visit note and explain what in the world just happened. And so if you can do a good job with building that relationship, care coordination is not just a service, but it really becomes the relationship that can carry across the entire patient's healthcare experience. And so I think that it's critical if you're going to win at value-based care. And the second thing that that time building the company gave me is a really deep understanding, a nuanced understanding of the behaviors of both the folks that provide these services, care coordinators, health coaches, care coaches, there's like 14 million names for these wonderful people, as well as the behaviors and processes of just care coordination, the way that patients respond, the way that it's really effective. And so about 2 years ago, I started thinking about how I can augment our team using generative AI. This was towards the beginning of 2023. Gen AI boom had just happened a couple months prior, and I had been augmenting my own workflows. And I thought, we've got to build something that is really, really perfect for the workflow of care coordination, and maybe even larger care teams, what I'm starting to call Middle Earth, all the folks between the patient and the doctor. And so looking at the market, I saw that there's a couple different approaches. There's an approach that is being touted by some that's kind of AI is going to allow us to, if we see it, we're going to automate it. We'll create AI bots. They're going to talk to patients. They're going to do diabetes management and education. I have yet to see that really play out in today's world. I think that everyone that has done care coordination will agree that if you had an AI bot just calling your patients and talking to them, you'd probably have no more patients to talk with by the end of the day. And so we really believe that you have to look at the inherent advantage that technology has over humans, and then look at the inherent advantages that we have over technology. And the way that it makes sense to me is that technology is simply inherently better at the brain of care, analyzing endless amounts of data, surfacing insights, and we are better at the heart, the actual delivery, the empathy. It's not just about empathy, it's that human-to-human connection. And so our motto at CareCo became, we want to build the brain to amplify the heart. If we could build something that took over all the tedious parts of care coordination, the pre-call prep, the post-call documentation, task creation, task management, communications, and then we allowed the care coordinators and the care teams to just care for the patients. How incredible would that be? And so we started this experiment. At this point, I'd call the official date maybe February of 24, so about a year and a half in. We launched formally in January of 25, and I'll go to this for a moment. And so far, we've finished I remember in April, we had about 10,000 patient conversations on the platform in the month of April, and I'll explain what the platform is in a moment. And in August, we completed the month with 45,000 patient conversations on the platform, and we're continuing to grow quite rapidly. And so the thought process and what we really built was, the first thing is we put all the old school communication systems built directly into one platform. And so as crazy as this was, here's a quick tip: don't build a phone system, it's not fun. But we built the phone system specifically designed for care coordination. We then built texting capabilities, video capabilities, and an ambient recorder. And the idea was that we have all forms of communication flowing in and out of one platform. And the reason why we really wanted that is not just to have everything on one platform and not for that to be fragmented, but because I believe that the most underutilized piece of data in healthcare today is the entire patient interaction. I find it incredible that so many health systems and so many healthcare organizations today are already using ambient recorders. They're using these technologies to listen to the conversations, technically analyzing the conversations. But then we slice this tiny, tiny little sliver off in the form of communication, and then we throw that in the chart. And then the chart becomes, it's a collection of what's left, and then that's what you're now analyzing for further AI tools. At CareCo, we want to grab the entire patient interaction. And we want to analyze that entire patient interaction and bucket it accordingly and kind of build a brain on every individual patient. And that's why we built all the forms of communication on one, so that we're always there enabling and analyzing at every point of conversation. Now from that, that's all meant to power our call guide. And I love that one of the points that Charles mentioned before was, it was one of those small little bullet points, but I'd really like to highlight it. You talked about in-office guiding and prompting. And that's really an extension of what we're doing on the care coordination side, and I love that. What we're doing is we're taking all that context, and then we stack it on top of an objective for any given conversation. And we say, what's everything we know about this patient from this entire brain that we've built? What are we trying to accomplish today in this very specific conversation? Much deeper than a care plan, much deeper. It's really, really hyper-personalized. And then our call guide will spoon feed the human care coordinator the exact talking points and discussion items that they can discuss today with the patient. And the beauty is that every single thing is citationed back to the source data. And that's once again why we want all that data on one platform. And so that's what our call guide looks like. And then post-call, we just do, and this is what you're seeing on the screen here, in addition to the gorgeous UX UI. When you get off your conversation, whether it's in person, a phone call, or a video visit, you would get the full transcript of that conversation together with audio. You get your clinical documentation, which is a standard at this point, fully customizable to any template that you'd like for documentation. You then get your tasks, which you could kind of see at the bottom there. And the tasks are probably my favorite part because it gives you just the actionable items that you actually have to do for the patient. And we even take it a step further. And if there's a message, if there's a communication that is necessary as part of that task, we'll generate that communication. And I think a lot of folks don't appreciate this, but one of the most stressful parts of care coordinators' jobs is sending messages to doctors. I know there's a lot of doctors around the table. It's intimidating to send you guys messages. And when you have to do that dozens of times a day, and you want to make sure that you're really constructing the perfect message, that really creates a lot of stress. So with that small feature, we were able to delete that stress. And then finally, there's a patient message as well that you can immediately re-engage with the patient. And so I have a lot to talk about as we go through the discussion. But I think that I would encourage all, see if there's any, yeah. So our mantra became, we want to build the brain to amplify the heart. And if you are, and I'd like to call out actually Advent Health, I know is doing a tremendous job with this and setting some of the infrastructure here at a health system level, but starting to think about grabbing this data and starting to analyze the data so that we can really do things like Charles mentioned before, and like we're doing at CareCo, of analyzing that data and then surfacing the perfect insights at every time and making the actual process of care better, not just for the patients, which is the end goal, but for the care teams as well. Thank you.
Fantastic. Thank you, Mendel. Last, we're happy to welcome in person a previous PTAC submitter of the Advanced Care Model Service Delivery and Advanced Alternative Payment Model Proposal, Dr. Khue Nguyen, who is the founder of M-Price Health. Please go ahead.
Good morning. Thank you to the committee and to my esteemed co-panelists. I think we're going to have a really great conversation. I think we're all coming at this in some way very similarly, and there are definitely synergies, so I'm definitely looking forward to the discussion. It's an honor to be back at the PTAC. Years ago, I came before this committee to propose the advanced care model, a high-touch, person-centered approach for the high-needs population. Since then, I have, through the experience of helping CVS ACO from scaling from concept into a national platform, I have witnessed firsthand both the opportunity as well as the persistent challenge that we all face in making truly effective care coordination scalable and sustainable. While today is a discussion, I can't help but view it as a call to action, a chance to put new ideas on the table, so thank you for this opportunity. In the last decade, I have been on all sides of this challenge, building from the provider level, designing payer strategies. We've leveraged EHR, interoperability, dashboard, risk score, registry, team-based resources. And while we've made progress, it simply hasn't been enough. Progress is too slow, too incremental, and we have largely maxed out on what's possible with the current sets of tools and approaches. Today, we have mountains of data, but they don't work well together in a simplified way. EHR, claims, registry. By the time insights can be surfaced, it's too late. The patient is already in the ED or maybe back in the hospital. We built a system that looks backward when what patients need is foresight. And that is the divide between data and impact. We've all talked a lot about team-based care. Care managers are the backbone of care coordination, yet the system burdens them. Every day, they spend countless hours searching the EHR, reviewing claims data, doing documentation, and unfortunately, leaving voice messages for patients and doctors. They rarely have time to truly synthesize insight or connect with patients in a meaningful way. Burnout is inevitable, and the model is just simply not sustainable. So, sorry for that kind of a depressing opening, but I think we have all experienced it, and the exciting news is we are entering what might be the most consequential technological breakthrough of our lifetime: artificial intelligence. AI offers the ability to go beyond retrospective silo data to create real-time, adaptive, personalized support for both patients and doctors. Imagine a system that not only looks backward, but can continuously learn and anticipate. For patients, AI can turn complexity into simplicity, translating medication changes, lab results, multiple care plans into a simplified, just-in-time, what does this mean for me? For care team, AI can be a co-pilot. It can triage high-risk patients. It can execute simple routine workflows. It can surface next best action. It can even make phone calls to check in on patients routinely so that we're now giving back time to the care team so that they can focus when it really matters the most. For health systems or for delivery system, the benefits are going to be compounded. Finally, the mission that we're all after, higher quality at lower costs. So committee, my message for today is this. We can continue to iterate with the existing tools and approaches, and we'll continue to get incremental results. But if we embrace AI with urgency and deliberation, we can realize the impact of improved lives right away. My call to action is, why wait? Let's dive in. So thank you for this opportunity and looking forward to the discussion.
Thank you, Khue. Thank you to all of our experts for those great presentations too. Let's flip to committee questions now. This time, PTAC members, please flip your name tent up, or for our virtual committee members, please raise your hand in Zoom if you have questions for our guests. In the interest of ensuring balance across different perspectives and questions, we encourage experts to keep the response to a few minutes. All right, who's up first? All right, maybe I'll kick us off here. You want to go, Jay?
Sure. I have a couple of questions for each of you that are a little different. I think for Dr. Neal, I'm curious as to how you're doing your curbside specialty consults. Are they phone? Are they electronic? Or are they through your care coordinators? Because one of the issues we've been talking about for the last couple of days is leveraging technology for informed patient decision-making, but really what's going on between the primary care physician and the specialist. So I'm really curious as to how you're leveraging or not leveraging technology for that.
Absolutely. Thank you for the question. We have two sets of specialists that we engage with right now. We have a small focused employed series of specialists, and then we have a third-party specialist or consulting firm that we have a vendor relationship with. And so I'll talk about that first and then bring it back to our home. So through them, we're able to access curbside consultations that involve the PCP sort of giving a little bit of a snippet of what their patient scenario is, what their question may be. And we get a response in writing and in video from that consultant within about 4 to 6 hours on average. The SLA is much longer than that, but we are able to share that and view it at times with the patient where necessary, whether that's synchronously or asynchronously. Meaning we'll bring them back into the center and we'll sort of review it together with them, or we can call them and let them know what the consultant said. Perhaps a greater source of pride is the internal ability to have PCPs be able to curbside specialists that are employed. And we do employ about 10 subspecialists within our practice and they have immediate, sometimes synchronously while the patient is in the room, access to curbside consultation via a tech platform that is almost like an instant messaging device or a texting device, if you will. And then that's how sort of we've engaged with patients. What we want to do more of is engage with specialists who are value-based care experts and really understand the model, understand our patients, and are able to give us advice that we can reasonably follow, that are cost effective, and continue to drive quality of care for the patients. And so we still put the onus on our PCPs to make that call, whether or not that specialist is giving aligned advice or they're giving advice that's really not practical to deliver to the patient in the scenario that they're in. And so does that answer your question?
Yes, that's very helpful. And I was curious, have you seen a reduction in ER visits and admissions along those specialty lines, whether it be cardiac or pulmonary and so forth?
Absolutely. When we, for example, cardiology is probably our most robust service line. When we have cardiologists that are engaging with the PCPs in a market, we can see up to a 50% reduction in hits on external cardiology providers, hospitals, unnecessary tests, for example, or repeating tests when that cardiology is engaged. And so it's absolutely a game changer for patients.
And my question for Mendel is, are you contracting out as a third-party vendor, or on a PMPM basis for health plans, ACOs? I'm curious to your business model.
Yeah, appreciate that. We have a couple different pricing models. It is a SaaS platform, so we are giving it to folks that are doing care coordination already. We want to upskill them tremendously. Absolutely spot on, ACOs, payers, health systems, and there's also quite a number of just third-party care coordination companies that are doing this work pretty extensively, and that's who we're licensing it out to. And we have a couple different pricing models, either per user or per patient. But when we do per patient, we do per active patient. So actually, patient engaged with on the platform for any given month, and those have been pretty effective.
Great, thank you. I'll go to maybe Lauren next, and Lindsay, and then Larry. So the 3 Ls. So Lauren, go ahead.
Thank you. Good morning. I'm sorry I wasn't on at the beginning. I was actually providing some complex care coordination urgently. My name is Lauren Hart. I'm Chief Integration Officer for HCG Strategies and a nurse by training. I spent the better part of the last 20 years really focused on model innovation for complex populations. So have a really broad lens around care coordination. I'm fascinated by your presentations. A couple of questions. I'm curious, in your work, so this is a question really for each of you. There's a lot of different disciplines engaging in care coordination: physicians, nurses, pharmacists, social workers, community health workers. I'm curious what you're seeing as which disciplines are most successful at this work, and what are you learning about that? And then my second layer of question is really around the importance of anticipatory disease and symptom management. What are you learning about that in the competencies that are held by the people delivering care coordination versus what can be covered by AI and some of these predictive tools?
I can just maybe get started here. Thank you for your question there. So I believe the first question is, is there a certain discipline that is better than others? I'm curious to hear from others. CVS ACO was managing over 1 million Medicare beneficiary fee-for-service lives, and prior to that, work at other health systems. And so I would say that, I don't even know that we would even be approaching that question. It's more of what are the resources that are available? And each discipline do bring their own focus. And so it's very important, to the extent that you're in a marketplace where you can bring in a full multidisciplinary team that's going to include your nurses, your social work, your nutritionists, your pharmacists, and even a lay care coordinator. You have that full suite, then you're very well-rounded. And the strategy often is, there's always going to be sort of your quarterback. And typically, that quarterback is best served by a generalist, such as a nurse or social work, depending on the kind of case. If it's a case that's more medically oriented, we would assign that to a nurse. And then to really leverage your other discipline for very targeted intervention. And so to the extent that you have that kind of a budget to the extent that the resources exist, then that's definitely the ideal picture. But oftentimes we're working with much more limitations. And so I don't think any of us here are questioning what needs to be done. It's more of how do we do it? How do we do it in a cost-effective way? How do we make this sustainable? And so that continues to be a challenge. I think that was the second question, Lauren.
I'm so curious with, we know that in best care, anticipatory disease management and symptom management is really important. And I'm curious what you're learning with what can be covered by AI, NLP, all of the technology versus what's held in the person providing it, and how are you teaching that?
Yeah, I mean, we're all here very passionate about how to make care better, and care management is really that, foundation to how we can make care better. But as you said, I think, we're asking our nurses, we're asking our social work to do a lot. These are complex cases. Oftentimes, those are the cases that get assigned. And so we get great anticipatory care with a very experienced clinician. Now, that very experienced clinician may be very limited in using technology, right? So there are these barriers, and we all try to optimize them. This is where I'm now, someone who's been so deeply committed to doing this work and have seen it at scale. I just see so much barriers, and I think this is where AI is going to really just change the equation. Charles, you talk about if we approach engagement with empathy and dignity, right? A skillful clinician can do that. And even on a stressful day, they'll get it right 90% of the time. Now, if you have that skillful clinician with an AI and you instruct the AI to always approach the engagement with dignity and respect, that AI is going to get it 100% of the time. So this is where AI is going to be superior in the sense of being able to anticipate, because AI has that ability, right, to really comb all of the information that you can give it to it, and then quickly within 3 seconds, be able to synthesize that and put in place, an analysis of, anticipation. What are we predicting is going to happen next?
Dr. Nguyen's answer was so eloquently worded. The only thing I'll jump in to add here is, in response to your first question, which is care coordination, where is it super successful? I think we will continue to have a challenge with care fragmentation so long as we have a different payment model or different incentives. Hospitals are driven by volume. You have full risk providers that are driven by outcomes. And those two inherently don't really connect with each other. And so them providing a specialist providers in ChenMed, providing us with timely information with which to help the patient to actually decrease the volume that they want to see. I don't know that we'll ever get on the true same page with that. And so where AI really does step in is that it empowers the patient and the PCB to be true advocates for health span, to be able to get ahead of a worsening disease state way before it becomes at the point of no return. One of the most proud sort of projects that we have here at ChenMed is how often do patients, for example, crash into dialysis? When a patient crashes into dialysis, meaning they have a hospital event that initiates dialysis, their mortality rate almost quadruples. If compared to if you were able to start that patient in a controlled outpatient setting with the family, maybe even starting peritoneal dialysis versus hemodialysis, and we were able to use tools that help us to detect when is that deterioration impending and how do we intervene in a proactive way. Now, the possibilities are even more astronomical with AI on the scene. They're able to really even comb the medical record every time that patient interacts. So we're not actually just waiting for the GFR or the glomerular filtration rate to drop, but we're actually looking, hey, is that patient gaining weight? Are they sleeping less? Are their health patterns changing? Are they coughing more? Are they more tired, right? And so these are ways in which we can get ahead for the sake of the patient, but we have got to get aligned on the incentives, because unless the volume is disincentivized, then we'll always be sort of fighting the two sides of the battle.
If I can add just a couple points, really well said about the incentive structure and the downstream effects and the fragmentation of communication. I think, though, there's also, even within every organization, there's still fragmentation of those communication platforms, and that is something that we can tackle today. And so to kind of go back to your first question of who is using, in our scenarios at CareCo, we started with just like traditional care coordination, and it's expanded to, we've got pharmacists, therapists, we've got home health nurses, we've got hospice nursing. There's quite a few of these verticals. And the more interesting ones are the ones that use multiple different forms of communication. So I like the home health example because 80% of that operation, so to speak, is in person in the patient's home, but then you've also got a call center. And so if you've got one hub that is analyzing all of that, and it doesn't matter whether you're on the phone or in person or video or texting, all that data goes to the same quote unquote brain, you're then able to pull out the insights that you need, and you're taking into account everything, even from the other kind of care team members of the other teams. And so it's a really interesting way to kind of build one brain that feeds all these different care team. And so that's been really effective. The other thing is, going back to your second question, my framework for when is AI effective, I think anyone that's going to give you a definitive answer of like exactly where AI should be is either not visionary enough or is just trying to be opinionated, which I generally am. So, but my framework for thinking about it is that the way that it makes sense to me is there's two types of patient conversations. There's what I like to call one-way conversations and two-way conversations. How I define a one-way conversation is if a patient is calling you because they need something. And in those scenarios, typically speaking, they don't actually care who's on the other side of that phone, whether it's an agent, a person, onshore, off, they don't get, just help me. That's what they want. And there's also a version of that for when you're calling a patient, different various assessments where you're just looking for information. That's all I need. Did you update your insurance? Yes, no. And so I think we'll see, and I don't think we're even there yet, because I think there's quite a stretch even between the healthcare kind of examples of this and even what's available from kind of the main models from a friendliness perspective. And there's still a lot of work to be done. But I think that's very different than what I call a two-way conversation. A two-way conversation is when you're reaching out to the patient because you're actually trying to affect something in their life. You're trying to change their behaviors. You're actually trying to change their health outcome around a certain chronic condition. And to do that, you really need not just to be inspirational and almost like a coach and you know, obviously the various tactics of motivational interviewing and all that good stuff. But I think that inherently there's something about human to human connection where, because we've all gone through something in our life, we can connect to each other and we can say, hey, I'm going through this rough time, and maybe I'll actually listen to you and change my diet and change my exercise habits and things like that. And that's something that I don't think will ever go away. And so I think, you know, we can even improve in the empathy, we can improve in various different aspects when it comes to AI and agentic voice, but that kind of core connection of, I know that I can kind of trust you and I can connect to you because we've both gone through something, I don't think will ever go away.
Helpful, thank you. Lindsay, did you have a question?
Yeah, thanks. So it sounds like we haven't totally figured out how to pay for the various forms of good care coordination that we talk about here, outside of maybe total cost of care models where you plan to reap the benefits of it in decreased total cost of care or improved quality or things like that. I think when we're thinking about potential payment models or ways to value this important work, I'm curious around how each of you might be thinking about how you quantify impact or how you show that it's working outside of waiting for those downstream markers we all care about, like lower cost, higher quality, improved all-cause mortality, whatever it may be. And so I'm curious, in each of your domains, what are some of those surrogate markers you're using? How are you measuring or quantifying the impact of what good care coordination might look like? So what SLAs are relevant? What are some of those things we might think about as you design a payment model that values it absent total cost of care? Or maybe that is the solve. But curious your thoughts on how are you looking at it along the way? How are you measuring success? What are those surrogate endpoints you look for to determine what good looks like? And I think maybe just some of the background is, as we get more data, more AI, there's always this pressure of, well, let's just pay for it. It sounds like a cool tool, or it sounds like a cool thing to coordinate care, but how are we showing that it makes a difference and that this added investment works?
Lindsay, I'm so glad you asked the question. I know it's going to be in the next session to talk about payment models, but I have been in payment models, so thrilled to be thrilled that we get to discuss this. You know, I think we're here at the PTAC, and we really have an opportunity here. You know, AI, one of the most promising breakthrough for AI is going to be medicine. You know, medicine has been so difficult because it's clinicians, it's human-to-human interaction, communication. And so AI is finally going to be able to crack that with, you know, the language of AI is human communication with the ability to synthesize. So all of that is to say, we really have an opportunity here with the PTAC, with CMMI, to really foster innovation. We've done a lot. We've done a lot in the last 10, 15 years with value-based care. I think no one ever debates now that we need team-based care, we need analytics. We're all doing that. So I think we can put a check mark on that. And now we need to go further. And so the only way to go further is through incentives, new payment models. So I would urge that, you know, one of the things that just occurred to me today is I probably need to gather other collaborators and submit an AI native approach to value-based care, because we really do need to start innovating, piloting, create the incentive for health systems, for primary care providers to really incorporate AI into their workflow, and for us to measure the impact of that. One of the, you know, if we take transition of care, it's a core intervention across all value-based care. We pay for it today. There are discrete ways, right? If we incorporate AI into a transition of care workflow, what can we expect? We should be able to expect that AI plus human is going to be able to do a better job with all of the surrogate measure, whether that's primary care visit within the next 3 days for high-risk patients, medication reconciliation, readmission rate. We could look at team capacity. There is just so many discrete measures where we can begin to really understand how does AI bring in that efficiency and effectiveness.
Thank you. Maybe on the phone, any thoughts?
Yeah, I'll just jump in to add. I think the question is an amazing one, and it truly is difficult, because we've been sort of after, hey, we get the outcomes numbers, and to your point, all-cause cardiac mortality. How do we get upstream from that to help our PCPs and centers know whether or not they have succeeded at today's tasks and the week's tasks, et cetera? And so now we're actually, it's a timely question, because we're on a journey now on how do we help, get ahead of that arrival in the hospital. For example, we pay attention to no-shows. very simply. We make sure that, hey, if the patient's not coming in, there's a reason for that. We pay attention to missed medication fills. We pay attention to, hey, did we actually administer urgent care level medications? When do we see that patient next? And so we have a number of systems that help us to notify the PCPs ahead of time. Hey, this patient is high risk. We want you to change the plan of care to one that's more urgent and timely. Ultimately, that end measure is super important. And it's going to be a mix of a calculation of those end outcome measures, as well as what is the cost or the business case for the avoidance that we see, and the quality of life that gets added to that patient, where their family member doesn't now have to take off of work or spend money missing days to take them to get a number of tests where we could have done that upstream. And so it's an interesting sort of conundrum. I do think that AI will help us to solve quite a bit of it, but we're going to have to enter very cautiously because that AI is even better when the users know what to do with the information or can equip it with the information that they can actually generate new learnings and new insights. But until we're able to do that in a robust way, it could be a tool that we pay for and we don't know how to really manage or operationalize its outputs. And so that's sort of from our perspective here at ChenMed.
That's great. Thanks for sharing. Yeah, Larry, thanks for your patience. Yeah, I'll go to you next.
Great session. The gears are spinning in my head here. Mendel said something that's got me thinking deeply. His statement was, build the brain to amplify the heart. And although I think that is absolutely fantastic focus, I want to ask a question about a little pivot from that. And I want to tie it into something Lauren asked. So my question is, can we build the brain to anticipate the care? Are any of you doing anything to move to more of a proactive use of AI to get to that symptomatic patient with a chronic high morbidity, chronic disease, using AI to anticipate their deterioration rather than acting on it once it occurs?
So I guess I'll start with that. I appreciate the question and the pivot. That's definitely what we're doing today. Is definitely still reactive. Even with our call guides, which we think is quite advanced, and we have a generation 2 that's coming out soon. That's going to be a lot more in the direction that you're wanting it to. We believe that we're laying the infrastructure to be able to do that kind of thing. And so I'll also kind of tie back some of Lindsay's question and some of the points that Dr. Neal mentioned. We talk about upstream. There is no further upstream, unless I'm missing something, than the actual patient conversation at the point of conversation. Everything from that point is downstream, everything that comes out of there. And the furthest downstream is claims data, essentially. And today what we do is, and so this is going to kind of tie to both, also about reimbursement from Lindsay's question. Today what we do is, in order to prove any kind of efficacy, you're basically running claims data and you're hoping to see a reduction in utilization based on claims data, which is so far disconnected from the actual original point. And so if I were to think about reimbursement for these tools, or for an idea, what I think is going to be super transformative, and what we are seeing already at CareCo, is that if you are analyzing and retaining and trying to be intelligent about this data, again, that you probably already are analyzing, you can now get such a more intelligent answer. If I'm the payer, that's what I would want to see. Because with CareCo today, you can just ask the question, how have I accomplished XYZ objective with this patient go? And it will give you an intelligent answer, citation back to the point of conversation where that happened. And so there's obviously carrot and stick versions of doing this, but if you want to talk about reimbursement, I think that submitting objectives and submitting kind of data and things that you've done with your patients, citation back to the point of conversation, and using Gen AI in that process would be a really, really, really practical and not that difficult way to start. And so back to what you were saying, that is definitely the vision. I think by analyzing and building kind of this brain that we're implementing on every patient, we're building the infrastructure to be able to do that. Because once we've got all those points of conversation, and to Dr. Neal's point earlier, there's still definitely issues with the fragmentation. At the end of the day, no one healthcare organization will get every point of patient interaction. But the more and more that you can get, you can start running that data to start anticipating more and more and more and better and better and better. And so, yeah, I hope that answers slightly.
Well, I think where my head's going with this is exactly where I think you have already gone, and that is that all these ambient recordings are going to allow you to build the AI agent that is going to take the superhighway you've created already with your infrastructure and replace the human-driven cars with Waymos. And hopefully that'll allow us to get to the deterioration before it actually occurs.
Yes, yeah, I think the tools exist already, and I think it's going to be here. We do need CMS, CMI, PTAC to create the incentives. But as you said, I think the AI not only will be able to just do a much better job of just synthesizing real-time, historical, large chunks of data and be able to really predict what's going to happen next. And let's just say that we agree in our protocol that this is a high-risk patient. This is someone that we want to see same day. Gianni, I'm sure you're nodding your head here. This is probably very similar to a Chen Med. The AI, you can instruct the AI to call the patient, and if the AI knows that this is someone who is, who's going to have transportation barriers, and here's the transportation plan, the AI can execute on that so that we get that patient back in the office within that same day appointment. So that technology exists and it's being piloted. And, I think we're going to begin to see a lot more of that. And as the government, we need to do everything to continue to push for testing, because that's how we're going to learn, that's how we're going to optimize, and that's how we're going to quickly be able to get to greater improvement.
Awesome. The only thing I'll add is long before AI was sort of so ever present in our lives, we attempted to do this with humans. And so we would have what we call the love call approach. And this started during COVID. We were not hearing from our patients. They were scared, they were isolated. And so we actually developed an outreach tool that said, okay, ask this group of questions. And they are seemingly random, but the idea was, how do you start to gather enough information and detect subtle changes that you can then act upon? And we developed a scoring system that would, develop the next steps or escalate to the next steps for that particular patient. Now AI can do that. If you speak to a patient, you can tell that they're breathless or that they're not able to complete that sentence even before they get there. If they're, if their pattern is different, for example, an ambient listening device can say good morning, and when they don't hear the patient, they, hey, what's going on? You didn't sleep well last night. Oh, why is that? I slept in the chair, not in the bed. Ding, ding, ding. They got to come in, right? So there were a number of ways in which we attempted to do what I'm super excited that AI can do for us, because it just equips the PCP in an ever burdensome environment to decrease the burden of decision making for them, that they can say, yes, that's a patient that I need to see now, or this is a patient that we can see for you, or the nurse can be deployed, or somebody can make a call, a pharmacist can fill a medication. And so it really helps to truly empower the PCP to feel as though they have control over the outcomes and that they can be successful in the value-based care model. Because what we see when people opt out is that they're like, it's too many, there are too many moving parts. I'm not able to feel and see the success. Well, thankfully, we've been able to bring that sense of progress to the PCP where they can actually feel like they're making an impact because we're decreasing that decision-making burden, bringing information to their fingertips, actually helping them to get upstream, and then they can be held accountable for the outcomes as a result. And so I'm excited about the innovation that's coming down the pike. It's going to be amazing for us.
That's great. Charles, do you have any comments to add?
Yeah, I just wanted to weigh in that, and I know Jim Walton was part of PTAC for a few years as well, and Jim and I did a lot of work in Dallas around care coordination, and before we learned how to spell AI, and it was everywhere, and this is going back 15, almost 20 years now, and one of the things that we learned is that patients, particularly patients who are vulnerable, either clinically, socially, or both, tend to have these episodic issues that may push them to the ER or ED and present barriers to care. And it was a very dynamic process to try to keep up with them and care and coordinate their care. And managing a group of community health workers and MAs that went out and did home visits, I learned that information gathering was necessary to be sort of regular, just to kind of check in and figure out what those barriers to care might be and coordinate that care. And it was a very humanistic sort of endeavor and exercise. And I think, and I agree with my other panelists that AI and the computational power, the collection and analysis of information presents huge, wonderful possibilities for us to look for patterns to try to understand where and when that intervention needs to occur, because providing extra care to all vulnerable patients is not feasible. But to try to catch them in those moments or days or hours before they need to seek emergency care can be quite valuable from a human and a financial standpoint. And the computational power data collection presents us the opportunity to do that, but it's still, at the end of the day, is going to rely on our ability to connect with patients so that we can understand what their experiences may be, as dynamic as they may be, and then respond to them in turn. And I do think, as my other panelists indicated, and as the previous question alluded to, I think that the incentive structure can help lead that way. But I know that there's a lot of work to do with that still.
That's great. Thanks for all the perspectives. I'll go to Chinny next.
Thank you to everyone. Mine's a two-part question. The first part is, what strikes me about the work that's being done to incorporate AI into chronic care management is that it also presents an opportunity to narrow the band on the sort of competency, I would say, or skill of the person doing the outreach to the patient. So, almost being able to study what is successful, what kind of words are used, how do patients respond to different things, and so driving that success and then translating that and coaching other folks to speak the same way and making that successful. So one, I'd love to get your thoughts on how you're doing that. I know that Mendel and Khue, you're probably, I see both of you nodding. The second part of the question, which I'd love to hear from Dr. Senteio and the rest of the panel, is if on today's structures, on the ACO structure, MSSP, the today's value-based care organizations, if there was a waiver or a quick change you could make that would better align reimbursement to support not just chronic care management in its current form, but being able to use technology to further incentivize that use, what would it be? And I know it's a two very different questions, but I do think that they're important.
I guess I'll talk for us. So to the first part of your question, there's one layer that we're accomplishing today, and then I'll tell you kind of where we're going with this. And so the idea of queuing up the right things for someone to talk to the patient about based on not just their own conversations, but just best practices, whether that's motivational interviewing or other forms, is exactly what we're doing. So we're kind of prompting them, and like you said, upskilling the people. And we're already seeing that in longer conversations, more valuable conversations, because unfortunately, there's quite a bit of care coordination that either are like super quick touch points, just like, hey, how are you? Do you need me? No, goodbye. Or they're just very talkative patients and you end up talking about the patient's pet for like an hour, and that doesn't necessarily go anywhere from a clinical perspective. And so giving them the right questions to talk about and making it, in the right way, with the right wording and framing, without at the end of the day being a script, is what we're doing today. But I think the real power here, and kind of our vision, is to start including, as we build this out more and more, psychology and persuasion, behavioral science into these questions, and into not just what to talk to the patient about, but exactly how to talk to this very specific patient, knowing their social terms of health, knowing all the context that we know about that particular patient. I feel that in all other aspects of our lives, we're being bombarded, whether it's, fashion and purchasing and fast food and all these different areas of our life, that there are entire departments that are trying to figure out how to make us purchase those things. And we don't do that enough in healthcare, and I think we have the opportunity to do that. So that's as far as the first part of your question. When you asked what is kind of a barrier or something that we would change to chronic care management, I wrote down one word with 7 exclamation marks, and that word is copay. So I know this has come up a bunch, but it always is astonishing to me that there are copays when it comes to preventive care programs. I think it's make a decision. If the point of this program is to save money, why would you inhibit literally 80% of eligible patients from joining? And that's what we're seeing because of an $8 copay. If it's not going to save you money, rethink the program. If it is going to save you money, why would you block people from taking a part of it? And so that is by far the biggest issue. I think that if you take away the copay and then you realign the incentives a little bit, so like I mentioned earlier, maybe intelligently proving some of the outcomes instead of just billing and hoping for the best, but actually citationing that back to source data of conversational data and giving more intelligent responses as part of maybe submitting some of this quality reporting, I think that'd be a really, really good mix.
Yes, so one of the biggest benefits of AI is going to be upskilling the clinician. I think, we're somewhat pretty generic in how we engage with patients, but AI has the ability to really do that adaptive learning and really understand each patient in a really personal way, and really figuring out, what is it that's going to really matter? Is it certain motivation? What would be those motivation? And so we're finally going to really learn about all of the different sort of nuanced engagement strategies. Why does it work for one patient, but it doesn't work for another? So we're going to be able to be much, much more customized, much, much more personable. And the clinicians, the human that are sitting, overseeing the AI, is going to benefit from that. We're just going to get smarter, right? And so I think this is definitely going to be one of those, another transformation that's ahead of us. In terms of payments, I don't even think we need to create a lot. I think maybe perhaps CMMI would just need to go out and just make a statement to say, look, you can incorporate AI assistance into your value-based strategies, if that's, if we're talking about, value-based payment models such as MSSP, or even in the fee-for-service, even in the transition of care, the TCM, the CCM fee-for-service. If we just make a tweak there right now, I think there's guidelines that said, it doesn't have to, it can be, a clinician, a non-physician who's doing the assessment. You need the sign off of a physician. Now, if we incorporate in, you can also incorporate AI as long as the human is in the loop. that's going to sort of give that permission to the marketplace to really start innovating. So I do think that a little bit of tweaks is all that's needed to really get that piece going. And I'm going to sit back for the second conversation here, but I also then think that CMMI and PTAC should really also be testing an AI native approach. That's not taking the human out. But if we were to redesign this, if we were to pilot a care coordination without any limitation instead of building upon what we have, right? We need to continue to tweak, incorporate it in, test that. I think we need to do that. We need to also create an innovation pathway where we said, look, start from scratch, innovate, pilot, and we're going to support you on that. I think we're going to need both tracks.
That's a good point. Folks virtually, any comments? Or?
Yeah, I'd just like to add that we had, and I'm just thinking about this, that we had meaningful use incentives. We had incentives to incorporate EHRs into what I called and learned at the time. I was doing my doctorate at the time, the sort of last bastion, the healthcare delivery, where we had manila folders with colored tabs on them, and we had incentives, right, to incorporate, to implement electronic health records. Wow, electronic health records. And it worked, right? It incentivized, accelerated. It sort of, we didn't rely on the market. We relied on incentives to incorporate EHRs into care delivery. And it had an effect. So I wonder if similarly, when you're at HHS, so I wonder if similarly there could be incentives for responsible ethical use of AI. We already know, unlike EHRs at the time, we already know the huge investments that are being made in AI already. And I just thought, well, why not incentivize meaningful ethical use, steer it to say, let's learn what we did with the Affordable Care Act. Let's leverage the good and sort of leave out some of the lessons learned from that and say, how can we also incentivize responsible AI for patient care in the goal of improving outcomes? Maybe there's something there to consider.
I'll just add in here. There's a beautiful thing where a provider and a patient can share the same or similar lived experience from a culturally similar life experience. And I don't know that AI could replace that totally, but I think we can come close. And so as we learn from a patient, what motivates them, what approach motivates them. In this environment, we talk a lot about patient autonomy and patient-centered care, where there are cultures that the patient seeks to have a relationship with the doctor that it's a little more paternalistic even, and for me, kind of walking that walk as a clinician where I was learning as I went along, I found it very easy for me to connect with patients who are from the island of Jamaica, where I understand that when they say they ate oatmeal, that means they put condensed milk in it, and that's why their sugar was high. And my colleagues didn't really understand that, right? And so there's something that AI can do, though, to help us bridge that gap, because we do have to serve these communities, and we can't always wait for that unicorn in some cases to come in that particular location to serve those patients. And so I do think that there is an opportunity for AI to train and help physicians, nurse practitioners, care coordinators, all of us interacting with the patient directly to understand whether or not our language actually landed with the patient based on their response and how we continue to get better. I do think there's some universal things that can be translatable all throughout, and that is what we're trying to focus on, training everybody to be nice, to be courteous, to be timely. And those are things that can be respected all across the continuum. I don't have much to add to the comments about payments, but I love the copay underscore exclamation Mendel. It is very frustrating, for example, that things like physical therapy have become simply out of reach for patients because of copays in favor of allowing some other parts of the plan to benefit.
Great perspective, thank you. And we have about 5 minutes left, so maybe I'll give Walter the last question honor.
Thank you, Krishna, and thank you for a fascinating discussion. You know, I always find it a bit ironic that we are looking to AI to help train us to be nicer people, but often that is the case. I did want to pick up on a theme of this discussion around maybe taking a more AI native approach and exploring that a bit, maybe pushing the envelope a bit there. So it's been said here and elsewhere that AI plus human interactions are better than human interactions alone, and I think or AI interactions alone. I think that's probably true. Although I guess I'm wondering if any of you have had experiences where AI interactions alone is sufficient. I think, Charles, you mentioned that this idea of pre-encounter chatbots and avatars allow for kind of private, empathetic discussions and social interactions with patients. Do humans need to be involved with that, or can the AI chatbot or avatar just take that on by itself? Another example might be, Mendel, you mentioned you do CCM. Maybe instead of the monthly call from the medical assistant, you have an AI chatbot do that. Maybe that might be an interesting use of a waiver authority. I'm not sure. And then in terms of the high needs population, how does this get operationalized in that population? So as a medical director of a PACE program, a lot of our patients don't even have cell phones, much less computers to access chatbots. Can AI just, what's the bare minimum technology that like a high needs patient might need to have in order to participate in this AI revolution?
Thank you. So kind of some of the points I mentioned earlier, and I'm really passionate about this. I really believe there's a difference between those one-way and two-way conversations. I think that there'll be more and more opportunity for AI to be effective, and that's the only question that matters. Like, no one's opinion matters. Is the patient actually getting better? Are they managing their conditions better? And so I think there's a massive difference between, first of all, in-reach and outreach. When a patient is looking for help, they're looking for care, even in the context of chronic care management, the calls that are being placed to the care coordinator are a world of a difference away from the calls that need to be placed from the care coordinator to the patient. And so I think the framework for thinking about it is, if the patient is reaching out to you, do they just need a thing to get done? And can that thing be done faster, better, and more effective with AI than human? And I think you'll find that's very different, once again, than me trying to reach out to the patient to really build a relationship with them. They're not in a place where they're looking to, make changes to their life, and it's my job to actually affect that change. And then just one interesting note, I think that all the quantity and time-saving things around AI are pretty much going to become table stakes. Many of them already are. So I think that the interesting parts of the conversation are not so much like the documentation and task creation and stuff like that. I think that's all going to be in every platform. The interesting thing is the quality, like you mentioned, can a human plus AI? And what I'm finding is that, which kind of logically makes sense, really depends on the volume of patients that you're seeing. So if you're seeing like, there are therapists that see the same patient every day. You're not helping them by giving them a cheat sheet of exactly what to talk about with that patient, versus if you're dealing with hundreds of patients a month. So there's also a volume kind of difference when it comes to what can I remember as a person. But yeah, my main point is just earlier, I think there's a massive difference between one-way conversations and two-way conversations. And I think if you're actually trying to affect change with the patient, there's a really core element there that I believe is human, that I just think is inherent to being effective.
Helpful. We have time for one comment, and then we'll try to get to closing.
I think the difference here in terms of AI native or versus non-AI native is simply just two different development approach. A non-AI native approach would be to take the current workflows, the current ways that we do work, and looked at, what part of this can AI substitute? So that to me would be sort of a non-native. A native solution doesn't necessarily leave out the human. I do believe that the clinician is always going to need to be at the table, but a native approach would be, instead of just, let's look at what we do today, a native approach is to say, we have these challenges, we have these resources, we have this new capability, how do we put it together? And I think, those are just two different ways of building things, and we need to test for both. High needs is something that I'm very passionate about. I do think that AI can play a role there, although it's going to be harder because this is definitely a very high-touch population. But a lot of the support is to the caregivers, and that's where AI can play a role. And AI can even have conversations, telephonic conversations, so you can still simulate that conversation. And so there's definitely places and opportunities there as well.
Thank you. Charles, were you going to add a comment? I don't know if I saw your unmute.
Yeah. I was just going to add that it's an interesting question about supervised versus unsupervised encounters with patients. And I guess I would like to see AI unsupervised in other settings before I saw it unleashed unsupervised with patients, like, I don't know, driving our cars, maybe flying us around, maybe before we get to the unsupervised mode with patients.
And I'll put us in traffic first. Great.
Really.
With that, you get the last word. Thank you, Charles. Appreciate it. I'd love to thank all of you for joining us this morning. It's great to have this be the kickoff session for day 2. Great discussions, great insights. Obviously, stay if you can for the next half as well. At this time, we'll have a break until 10:50 a.m. Eastern. Join us then as we have a great set of experts for our final session today, which is on payment models and benefit design improvements to enhance patient empowerment. Well, thank you all.
Produced by the U.S. Department of Health and Human Services.